Yes. May I confirm that my screen is visible and I'm loud
It is
enough?
visible and you're clear, loud and clear.
Thank you so much. Hello, everyone. I hope you're doing well. My name is Eric, like I was mentioned, like I was introduced. I'm currently in Rwanda, but I'm a medical doctor trained in Uganda, in Gulu, at Gulu University, currently pursuing my master's in global surgery at University of Global Health Equity. Uh, it's a pleasure to talk about primary trauma care programs as a way of strengthening emergency response in low resource settings. You realize that by the end of this discussion, what we all aiming at is that no one should die of preventable deaths that are related to trauma. And that's all that primary trauma care is about. We want to avert those deaths that can actually be prevented through timely and appropriate intervention, especially on scene, when the incident has just happened or happened a few minutes ago. Um, I have, I should say, the biggest disclosure is that I've worked with Primary Trauma Care Foundation based in UK, but as well as the chapter that I was established in Uganda, in the northern part of the country in 2022. So, going to be more about primary in the northern part of the country. Uh, yes, I like to begin it this way that trauma has for long been a forgotten pandemic. I think the term pandemic now resonates much in the ears of most of us. But when it comes to trauma, I think it's something that is really that has been neglected for quite a long time. And if you read a paper written by Nigel one of the prominent orthopedic surgeons in significant gaps in trauma care, very significant. I think most of us, if you're familiar with the trauma data, you've had a comparison of mortalities caused by trauma as compared to those caused by TB, malaria, HIV, and they lately concluded or capped COVID-19 pandemic. But still, if you added all of those, they are almost like half of what trauma causes. Trauma causes more than 5 million deaths annually on across the world. But even those 5 millions that are captured, they could be underestimated. There could be some bit of underestimation because we lose more people before they reach the hospital, and therefore those go undocumented. And it's not surprising that still the curve is skewed to low resource settings. Uganda, Sub-Saharan Africa at large still suffers the hugest burden of trauma. And that's why we, as the low resource settings, have to be proactive to address, this burden in our settings. This is data from the Global Burden of Disease website. You'll see that this heat map shows about the burden of injuries or trauma. And the bigger the size of the flame, the larger the proportion of the burden. But one key thing to understand is that still road traffic accidents or road injuries in this regard still account for the largest proportion of trauma-related injuries. But again, there are others like, self-harm, violence. Busoga has done a lot of work in gender-based violence and its implications like physical harm. You still see that there are things of self-harm in terms of relating to suicide and all that, but there are also other causes like falls and drown. These are epidemiologically variable depending on the region because, like for example, if you're in the northern part of Uganda, rarely that you really have a drown incidence. That might be maybe in a swimming pool, but again, when you go to Busoga, where we bordering Lake Choga and Lake Victoria, you still understand that actually there is a high prevalence of cases of drowning, and that might actually compare to the instances of road traffic accidents. Um, well, still in our country, road traffic accidents are still comparable to the global burden because they are causing the largest proportion of deaths that are related to trauma, and they are the leading causes of death. Um, However, we need to understand that despite the current efforts, the trend is still increasing, meaning we've actually not done enough, or we're actually not doing enough. Like, for instance, between 2022 and 2023, there was a 16% increase in the incidence of road traffic accident. And that does not come with life, but rather death. Uh, I think you saw this paper, those of us on call who are good at reading papers, where border borders were called the wheels of death in the Daily Monitor released in October 2024 last year. I mean, it speaks a lot. It's not just by design, but it speaks to how one of the most commonly used, transport means is actually consuming us, and we are all dying. And small precautions such as helmet, both for the passenger and the rider could actually save lives. But I mean, how much are we doing in this line to really ensure that we keep ourselves and our people safe? Talking about Busoga, well, you might say that we relatively doing fair, but still people are dying. You see a cumulative figure of over 6,700 deaths. That's just from the eastern part. And now when you add to the northern Busoga region 213, then Busoga will contribute a total of over 4% to the national, road traffic accident burden as of 2023. That's significant enough because it hinders our vision, our mission as Busoga Health Forum, which is aimed at really improving the lives of people of Busoga. You've seen this. I brought this. It's just 2023, but still, just to let you know of how trauma is consuming our people. And not forgetting, most of people are dying are really young, and data shows within a range of less than 35 years. Those are the people that are mostly succumbing to trauma. And that's the most productive population we have. And the largest proportion of Ugandan population is actually made of young and working group individuals. And yes, the latest one I saw in the news was that two were killed and several were injured in the Iganga and Mbale highway crash. I mean, isn't really trauma, a big burden that we need to address? That's a question I'll ask you, and perhaps even those who have been on the way heading home, you might have seen some accident happen on your way back home. Uh, this is one of the tweets that I like most because it speaks to the burden that we are having. Dr. Kabanda, the minister in charge of health education and promotion in Uganda, put this tweet, but I don't think many people really gave it attention. Even His Excellence was tagged, but well, I think I needed to go back and check how viral it went compared to, to the famous musicians. I think some of these things really have less attention, yet they deserve the most attention ever. He said we need urgent remedy to address this killer. I don't know if to you, from the data so far we've had, you really think we need an urgent remedy. But on my side, I really think we do. Uh, Besides trauma, road traffic accidents, like I mentioned, Busoga is uniquely, burdened with issues of drowning. I think that's another aspect I wanted to bring in. And you see that from these statistics, Busoga, when you look at Ginger, this was a study that evaluated the prevalence of, drowning instances in the region, in different districts of the country that are the lakeside. When you look at Ginger, it has a cumulative figure of 116. When you look at Mayuge has 49. I mean, these are our people. They are trying to earn a living. Most of them die fishing, others while on their way during transportation and all that. And yes, I think as we think of trauma in trauma care in Busoga region, we might not actually just focus on road traffic accidents. We need to put it awesomely to address even some of these highly prevalent incidences of drowning. And yes, I believe at this point we should be arguing and saying that trauma is really something that is causing a huge burden in our community, that is hindering our progress. For I'll give you three reasons in this regard as to why we need to really be proactive and work towards addressing trauma with urgent need. When you look at the vision of Busoga Health Forum, you've seen that it speaks about people living healthier, more productive, and living a more fulfilled life. I mean, how are you going to live healthier? Studies have shown that just a closed, a fractured tibia will make a Ugandan man stay in the hospital for more than 18 months. Do you think that person is really living healthier? Is he really living a productive life? He's going to be debilitated. And again, economically, is he really contributing or he's being drained? You know how the catastrophic expenditures that are related to health care, especially when you look at trauma. An implant will cost you 12 millions. And if this has been a peasant farmer or someone has just been relying on subsistence farming, I mean, their productivity, their field life is really not fulfilled. And as a country, we have the vision of 2024. I don't know if many of us know about this. You would not be a patriotic if you don't know about a vision 2040. but it speaks about transformation from a low income country, to an upper middle, not just upper, but upper middle. We want to be somewhere, even, close to high income country. My question is, do you really think we can make it if we are still having young, productive individuals die because of trauma? And again, it's not just the vision 2040, but look what the sustainable development goals that we just 5 years away from sealing the agenda. But shall we have achieved the sustainable development goals if our people still die because of preventable deaths from trauma? I really think we shall not. And that's why today, ladies and gentlemen, we need to be more proactive, especially regarding primary trauma care, the care that is given on scene when the incidents has just happened, such that we avert, the life-threatening conditions. I always joke around with my colleagues that it wouldn't benefit me to sit, in the consultation room and wait only to receive a patient who has died because they didn't receive care while in transit or while on give you insights into what we've done, how we're doing it, the impact that we've caused, and how Bosoga Health Forum can contribute uh, to the health of people in Bosoga region through primary trauma care program. Uh, it was found in the very first course was taught in 2010, and that was under a project called Cool. Cool standard for COSEXA, Oxford and Orthopedic Link project. You see that over, almost 800 providers were trained and were also trained. This program is in a sense that as you train a provider, some of the trained providers are selected to actually undergo instructor's course. And that's what happened. Uh, Through this program in 2010, Mulago Trauma Center was established, and that was under the leadership of Professor Moro uh, Emmanuel. I hope some of us here on call know him. He's a retired professor of of surgery at Gulu University. And there was, intra-institutional primary trauma organizations. Uh, the course was taught in Lira, in Gulu, and then it moved to a level that the course had to be incorporated in the medical curriculum for medical students at Gulu University. And it's a part of the routine teaching, so that, before you exit medical school, you actually get to have these competencies. However, there was a gap from 2010 to all that. But again, we are lucky that we're approached to with funding from THET. And that made us deliver this course in northern Uganda, majorly focusing on regional hospitals. Our hypothesis or philosophy was if we trained health workers in regional hospitals, we would actually, cascade. They themselves would cascade the training to their lower facilities and therefore empower the entire region and spread the training to the entire country. Like I said, it employs a 2 by 1 by 2 day training model, or you can call it a cascade model, whereby in the first 2 days you train providers, and of those, basing on the competencies expressed, leadership skills, and willingness to participate in a one-day instructor course, then instructors are selected and taught to instruct this course. It's one and is another thing passing on the knowledge. So having an understanding of the pedagogies and concepts and principles of adult learning helps you to deliver the content appropriately. So there in the instructors course, we mainly focus not on the content but the method, how to deliver, the different approaches, didactic versus simulation versus group discussions, and more of student or learner centered approaches, so that we maximize the outcomes of the learning. Then the instructors that are taught in a one-day course go ahead to instruct on the next two-day provider course. Still, it's not that we leave them to do whatever they can, because they've just gained the knowledge and the expertise. So we still supervise them and then guide them as they teach, where and clarify and all that. We also help them in the entire organization of the process. That's the end of external faculty. The very first course involved external faculty from UK who trained us as local providers, and then so it was our responsibility from Guru to take it to leader, to take it speaks to still sustainability, local ownership and sustainability. So that's why a pool of local instructors was created. The figures are quite obvious. 196. It was just in a space of two months, because it was November to December. Um, 41 instructors, trained. We had to give out materials wherever we went, simply because we wanted to encourage them to cascade the training. The models that we built, yeah, things to do with chest drain. You could develop a model and give it out, or even the materials. We went ahead to print some of the course materials and gave them out. But still, you need to know that materials are freely available on the website of Primary Trauma Care Foundation. So in addition to the hard copies, we still shared the links, such that, even when the hard copies were out, someone can refer to the online versions and be able to retrieve everything without any hurdles. Um, During the training in Yumbe, we actually pleased to have a team of four surgeons from South Sudan. It was very exciting to see how enthusiastic they were about taking this course to their home. So they attended both the provider and instructor course, and at the end of the day, they had to actually initiate the training in South Sudan. And that very year, that was 2022, but in 2023, they actually conducted their first ever primary trauma care training with the expertise and the resources that we had given them. Still, besides that, as part of the entire process, we had to establish a committee in the northern part of the country, with the aim of that being the focal point from which we would actually spread the entire program to all the country, and including Busoga region. Dr. Mukembo is one of the instructors, and he's one of the members of this committee. Dr. Magada Sam, he's actually the committee chair, and I know he can't wait to have this training conducted in Busoga region. Yeah, so someone might be asking what's so unique about primary trauma care? I mean, you've had all these trainings, but what is making it superior over others? Uh, One of it is the relevancy. Uh, this course focuses on the very people that really matter. The first, contact people, the the frontline health workers. You will see that in most of our settings, we are actually not having a privilege of having even a trauma surgeon, not even one in most of our settings. Most of the surgeons we have are general surgeons, but even the general surgeons are not readily available 24/7. They are in theaters working. But who sees the patient first? Is that nurse at casualty, that medical student who has just crammed the insertion and the origin of the muscles, and one just to save life. But if not having the appropriate competencies, they will miss it. So that's the relevancy of primary trauma care, training, that we get the very people that are involved in care, empower them with the most basic life-saving skills. I mean, even just the position of a pregnant mother, as you're waiting for for her evaluation, will matter, because it will either make your patient die in seconds or will save a life. Just applying a tourniquet or splinting a limb will save you from more complex injuries, including the vasculature and the nerves. So that's why we give them those skills. But furthermore, primary trauma care course is contextual. We look at what do we have, what's the burden of disease in our settings, what's the epidemiology of trauma, and you if you happen to see that it actually is a burden of trauma. That's the first lecture we give, because we want everyone to keep relating to what happens in their setting, and therefore contextualize it to their setting to maximize the outcomes of the training up to the patient level. So the other aspect is cost effectiveness. I know some of us are very enthusiastic about finances. Baby could say take a cent wall. So sente tugenda ziteekawo tulaba. I mean, when you compare, for example, primary trauma care course and ATLS, the advanced trauma life support course, it's very, the ATLS is very expensive. You see that it costs over, 600, um, euros, just to train one instructor of ATLS. And again, the aspects of ATLAs are not the very basic that we really need on ground. Some of them are very sophisticated that we don't even have a luxury of having some of the equipment to units. Will cost you over 200, like 250 pounds, euros, for you to have one instructor trained. But again, with the model of cascade, that you have the external come in and train locals, and then the locals cascade it, that's when you're going to actually see a cost reduce. because most of the expenses are more in, transporting and then accommodating, the visiting faculty. So that's how cost effective it is. I mean, per every individual train, just spending, less than 100 euros, you've conducted a training of over like 20 individuals. I think that's very cost effective, and we have reasons to really invest in this. Uh, Lastly, I want to talk about sustainability. Most of projects fail, and you've seen the gap from 2010, to 2022. Uh, no primary trauma care training whatsoever. We don't know if in Lila or Mulago they were speaking to each other. But again, it was not documented. We always have a saying, not documented, not done. So sustainability in this regard talks to the resources we use in conducting this training. Most of the models we actually use are low-cost materials. We build the things. If we visit Busoga today, if you have banana fibers, we shall use banana fibers to craft the models. If you have wood or water bottles, we shall use those to simulate a chest tube insertion. We're not going into complex models such as live animals and all that. No, we use what we have because we believe on scene you're actually not going to have all these fancy things, and most of our hospitals are actually ill equipped. They are not having all these fancy equipment of a manufactured cervical collar. No, but we'll use that box that has had normal saline in it and use it to develop a cervical collar that can support someone's neck from developing other injuries. Again, the other very, very unique part of the course is how fun it is. I think I enjoyed this course to the maximum because I was teaching pediatric care, and pediatric emergencies are one of the challenging emergencies. So I had a privilege to, simulate, you know, craft scenarios to ensure that learning is more appropriate and brings the point home. So besides getting the content, you get the fun because we use standardized patients. Those are like individuals to act. They do role play, the nurse, the doctor, and then we see how you work around each other. That causes cohesion between the teams. The other aspect is multidisciplinarity. We have the nurse, the midwife. Some hospitals were lucky to have the surgeons participate. I mean, that's a bond which we've always violated when we are in theater. The anesthetist and the surgeons are almost parallel, but they are working on the same patient. So PTC brings them together to ensure that they work closely as a team for the betterment of the patient. Um, so what do we do now to strengthen emergency care through primary trauma care course? One is that we need to scale up this training. We conducted it in Gulu had had the Lacho and all the neighboring hospitals. They sent in their health workers to be trained. We went to Alua, Lila, we went to Yumbe. We're not sure if those centers actually cascaded the training, but we need to do that. And again, it shouldn't be a northern Uganda thing. We need to cascade this and bring it to up to the eastern part, because, like we've seen in the figures, the eastern and all other parts are still affected by trauma, though by different causes of trauma. we need to advocate for this, not just to be a periodic, kind of program. It should be something that is part of, the institutions, part of the hospitals. I understand hospitals always have CME programs, and some of these activities are actually within the hospital budgets. So we need to incorporate them into the hospital CME programs such that we know that at least once in a year, all hospitals run a primary trauma care course and therefore update their different health workers on, on these skills. Again, when you look at the medical curriculum, it's something that we can always actually push to have in the medical curriculum as either, a mini parallel curriculum or as a short course within the main curriculum. And that ensures sustainability. That ensures that we are not just conducting the training one day and we forget about it for months until when we receive another grant. So we need to own it and do it for us and for our people. We need to lobby for more partnerships and fundings because, I mean, without funding, that's why you saw that gap of over 12 years not training. Lately, we also working on some other grant, but I mean, these are slow processes. Our people are not waiting. I mean, accidents occur every day. So a grant process can even take you 3 years when, I mean, you're losing lives every day. So that's why we really need to source whatever we have and ensure that we put this on table and address it. Now, talking about primary trauma care, I want to emphasize the point of lay first responders. On the right, you see, I just made a presentation yesterday or during the Uganda Association of Surgeons of Uganda's conference, talking about the need to improve on scene trauma care and why we need to scale up these courses. What I've talked about earlier in the previous slides is about in-hospital, care and management. But a significant number of people don't reach the hospitals. Therefore, we need to find them there. There are people who are actually there. There is one ugly photo I saw on social media. Others are dying. Someone is taking a selfie. I mean, they could not, they might not have wanted to do so, but I mean, they have no option. Is seeing an ugly wound. They are anxious, they are scared. They're like, oh, let me take a photo. I saturate, maybe help will come soon. You see? But if everyone has competencies of, curbing and controlling hemorrhage, sucking out secretions from the airway, then we cannot lose people. So we need to have a movement to actually empower border people, to empower the community, to empower the police. You see how police carry the people. Eh? Eh, I mean, it's someone will have a pelvic fracture, but you're holding them by the belt and you're destabilizing everything. I don't think such a person will really survive from those severe injuries. So, and again, how do we ensure that we have a national-wide scale up of this program? One strategy is to actually have this incorporated, for example, in the border riders licensing. Currently in Uganda, everyone I think rides as long as you you don't know. I've even seen a 5 year, seven they ride. But again, if it's put as a requirement that you must be licensed, then we can put it as part of the licensing. For police, as part of police training, we can put this and then also put measures in place to ensure that they have refresher trainings. Um, for the tax drivers, the same as you go to renew to get the first license, renew it. undergo through this training so that you refresh your skills. And I think that's really one very way we can ensure that these programs are scaled up nationwide. And at the end of the day, we shall definitely see a change in the burden of trauma. So now, how do we bring this to Busoga and ensure that Abasoga they are living well? But these trainings before. One is you have a huge burden of drowning and other different causes of trauma as opposed to say to road traffic accidents. That's when you look into redesigning and making the course more appropriate for that setting. So I think when we think of bringing it to Busoga, that's one thing we would do. But again, I must re-echo this that the course is free. All we need is the partnership, the willingness of the regional leaders, for example, the heads of Busoga Health Forum, um, and input of each one of us to have this training. Like I made mention earlier, Dr. Mukembo, Dr. Magada are key leads in this program, and therefore bringing this to Busoga, it would be really something that is not quite complex to execute. So I hope by the end of this, we shall get to strategize and see how to really have different hospitals in the Busoga region have their health workers trained in com. I know the attention span is always short, but if you forget anything from this presentation, at least don't forget that primary trauma care course is one simple, is cost effective, is scalable, and has shown impacts in resource limited settings in terms of focus now should actually be more of widening, especially the lay first responder program. The same primary trauma care course can actually be adopted and taught to lay people, not just health workers, being done in some other countries. So it's just a matter of, again, contextualizing the content you have and then delivering it appropriately. Uh, as a researcher, and as someone who is really interested in systems development, I can't go without talking about the need for data. You see, and when you, for example, talk about drowning, I've seen a paper talking about drowning and showing how there are big gaps in capturing of this data. But I must encourage us to be the ambassadors of quality data and appropriate data keeping, because it's through this data that we can know, one, the burden, and set priorities on what to act on first. I like how the entire profile of Busoga Health Forum was built. It was built basing on the data, showing you that over 40% of individuals in Busoga are living below the poverty line, showing you that this percentage of women, are suffering gender-based violence. And that justifies the need, to have the trainings in that regard, to act in those regards as equally as for trauma, like I've put it. So we need right from your, clinical registries to the national and level. We need robust data collection mechanisms to ensure that we not only just understand the burden, but we can also measure the impact of our trainings. Most of these trainings are actually based on, we always assess them in terms of immediate outcomes. Changing knowledge. I mean, if you're a good teacher, do you think you can teach and someone does not really gain knowledge? Unless there are those factors, definitely absenteeism and all those. But I mean, it's quite obvious. Someone can just recall. That's just a recall. But you have to be a critical thinker. You have to apply the knowledge. And we've always capturing how health workers are applying this knowledge and what's the impact on the patient outcome simply because we don't have data in place. So we must keep data, ladies and gentlemen. Lastly, I have this envelope since the month is ending. Um, Yeah, I know most of us have the brown. Mine is white. You just scan and then it will give you all the training materials for primary trauma care course. I'll give us a minute to scan and then I can move on. Well, I think we're all there. Thank you, ladies and gentlemen. I can't forget to acknowledge my mentors, the people I've worked with on this project, especially Professor Moro. He has been the key lead. He's actually the Ugandan ambassador for primary trauma care. He's working tirelessly to see that we can get another grant. But again, before we get another grant to cascade the training, I hope with the little resources we have in UGHE Forum and the contribution of all individuals on this platform, we can still take this training to Busoga. Thank you, and those are some of the references.
Thank you so much, Dr. Eric, for this beautiful presentation. And I'm glad I followed this presentation. We agree that there are a lot of road traffic accidents and other accidents that lead to trauma. And this session was really so key to even the primary health workers because they're the first people to see these patients. Uh, so thank you so much. This time, I want to see some responses and some questions from participants. So if you have a question or a supplement, raise your hand, and then you give it to Dr. Eric. He will give you an answer. Yeah. For the CPD link, kind of check the chat. You get the CPD link. But I also to encourage other cadres, nurses, midwives, pharmacists on call, kindly register your attendance. The link is not only for doctors. Everyone is encouraged to register. At this point, if you have a question, kindly raise your hand and give you a chance. As the question comes, there is one in the chat from Sylvia. Thank you for the presentation, Doc. I have a question about PTC training course. Where in Uganda do we find it? The institutions or it's an on-site train or mentorship? She's interested. Do we have anyone with a question before I give Dr. Eric a chance to respond to all? Ismail, you unmute. Do you want to talk? Or pick some questions from members or you type in the chat. Okay, Dr. Eric, do you want to answer to Sylvia?
Thank you so much. I think actually answered during my presentation. The course is still more in the northern part of the country and is under currently control of like the Uganda, Northern Uganda chapter of primary trauma care. And we are the leads, like I said. We still have everything, all the materials, the mannequins, all the training resources, and we are just a call away from anyone, any institution. So if you call us and we discuss about the logistics, we're ready to deliver this course free of charge. And again, not to limit you, I've shared the envelope, hope you scanned. It still takes you to the course. And I see Prof. Nigel Loster is on call. I'm very excited. He's our greatest mentor in this field. He has also shared the link. I think if you allow me, I'll request him to just say hello to us.
Yeah, he's 100% alive.
Hi, everyone. Congratulations, Eric. Lovely presentation. If anyone is interested in getting involved with PTC, I'm sure you can contact Eric and he can put you involved. But I can also stick a link in the chat for you, contact form, and we put you in contact with anyone pretty much in any country that you're interested in. The project is presently running in 89 countries around the globe. We've trained over 1 million healthcare workers, and we would be delighted to help you get involved. So well done and good luck.
Thank you so much, Prof. Nigel. We are humbled to have you on.
Perfect. Thank you, Dr. Eric. Do we have any question from anyone else? A supplement? We only have 1 minute, the end of the session. I will take on anyone who is willing to talk. Okay, I believe we don't have. At this moment, I want to come to the end of this session. And I want to say, Dr. Eric, thank you for this presentation. This is a certificate from signed by Professor Peter Waiswa on behalf of Soga Health Forum. And we are thankful for this remarkable presentation on primary trauma care, strengthening the emergency response in low resource setting here at Soga Health Forum today. I know you've presented from Chigari and you've benefited the entire country with such a beautiful presentation. Thank you so much, Dr. Eric. Maybe you could say the last word before we end the show.
Okay. Thank you so much. I'm really very humbled to have this. It means a lot. It inspires me. I remember the last time I talked about trauma, I was named Mr. Trauma. Uh, and I mean, I'm really very excited. But m- my last remarks would be to encourage us, to take up this initiative because I mean, today is someone you don't know. Tomorrow is your very own relative or friend. But again, the other day could be you. So if we don't really fix the system, then everyone is susceptible, everyone is liable to, succumbing to this. So let's work together, and I hope to really get in touch with the leadership of Busoga Health Forum to see how we can conduct this training in the Busoga region. Thank you so much.
Thank you so much, Dr. Eric, and thank you, participants, for joining in. We had a climax of 100 participants today. So I want to invite you next Friday, the same time, and also to encourage you to become members of Busoga Health Forum. And I promise Dr. Eric shall be working so that we collaborate to teach more health workers with primary trauma care. Have a good night. Thank you for joining.